Hi, today we're going to be talking about trajectories of female urinary incontinence. So thinking about how women with incontinence progress from one time to the next. My name is Laura Kaiser, and I'm joined by my colleague Jessica McKinney. And we've been kind of done a deep dive into this literature for some time now and are kind of eager to share kind of a synthesis of the findings. This is just to remind our audience that these slides are intended for healthcare professionals, and to let you know that LEVA, pelvic health system, is intended for the strengthening of pelvic floor muscles, rehabilitation and training of pelvic floor muscles for the treatment of stress, mixed and mild to moderate urgency urinary incontinence, including overactive bladder in women. And I'll just leave this slide here for a moment. And then we'll dive in. So thinking about the progression of urinary incontinence, when we first dove into this literature, we were interested to find out, how women, different women, progress from younger ages into older ages. So what do those trajectories look like? And what we found is that it's quite a complex picture. It's not necessarily linear, where a woman has perhaps an episode once a month, then once a week, then once a day, but that we see this kind of complex trajectory over time. And many women will actually transition from periods where they are symptomatic and to periods where they're not symptomatic. And this can happen over a period of months, years, and decades. What has not been done in the literature is any kind of formal disease progression modeling, meaning that we could, researchers have come together to draw any firm conclusions about this natural progression of incontinence. So to kind of put these puzzle pieces together, we'll look at some population level studies about incidence and remission of incontinence, and then dive into the data about health and function of women with and without incontinence, and look at how the data on research, the research about how UI is a risk factor for other health problems. And then finally, we'll kind of get a little bit more granular and think about the individual and how individuals can have different trajectories of incontinence over time. So starting with some of the population level research, we'll look at this idea of relapse and remission and then transition of incontinence. So I think most people are familiar with the three primary types of incontinence, but just to review, we have stress incontinence or activity or exertional related incontinence. We have urgency incontinence, which is associated with a strong and sudden urge to urinate. And then there's mixed incontinence, which includes symptoms of both stress and urgency. So when we think about transition in this context, we're thinking about transition from one subtype to another subtype. So there's three large studies that I'd like to discuss. The first is from an author group that was interested in looking at this idea of transition. So what happens when women have one type of incontinence at time point A, and what are their symptoms at time point B? So they looked at a little over 2,000 women who had incontinence at baseline, and they surveyed them every 6 months for a period of 4 years, asking about their symptoms. And what they found is that women with stress incontinence or urgency incontinence were more likely to transition to mixed incontinence. And women with mixed incontinence were much less likely to transition back to stress or back to urgency. So this idea that perhaps mixed incontinence represents a more advanced disease state is sort of one possible conclusion. They also found that women with stress incontinence tend to experience remission and recurrence. So women with stress tend to kind of relapse and remit over time, and this occurs usually at younger ages. So in the fifth and sixth decade of life, and less severe symptoms were less likely to transition to mixed incontinence. On the opposite side, women with urgency, particularly those who had symptoms for at least 2 years, they were more likely to transition to mixed. So you've got this this idea that perhaps stress and urgency kind of leads to mixed incontinence over time. But keep in mind, these women were actually surveyed every 6 months. So the same author group actually did a similar study, much larger group of women, where they surveyed women at baseline and 4 and 8 years. So there was a much longer period of time between these symptom surveys. And in this study, they actually found that the majority of women with either stress or urgency had the same subtype at the 4th and 8-year mark. Again, they did find that women with severe symptoms, particularly at onset, they were more likely to transition to mixed incontinence. So again, this idea that mixed incontinence seems to represent something that's a little bit more severe than stress or urgency alone. What they found in this study, though, is that yes, women with stress or urgency tended to transition to mixed, but they also did find that some women just had a new onset of mixed incontinence. So mixed incontinence is not necessarily a progression. There are some women that will just develop both symptoms around the same time. They also identified some risk factors for either remaining with or progressing to mixed incontinence. And we've already talked about symptom severity being one, but also older women aged 70 and older who had stress incontinence tended to be more likely to then transition to a mixed incontinence state. And then women with obesity and any UI subtype were also more likely to transition or progress to mixed incontinence. Overall, they did find that remission rates were low, though granted, they only surveyed women at this every 4-year landmark. So it's possible that women had remission, in the interim where they were not surveyed. But on the whole, when, at these 4 and 8-year marks, women tended to persist with their incontinence symptoms. And one conclusion that the authors drew from this study too is that the majority of women do not seek treatment. So these observations that we're seeing can truly represent sort of this natural history of incontinence in some respects, because and they cannot be attributed to any kind of treatment-seeking behavior. One final kind of large-scale population study also looked at this idea of incidence and remission rates. So again, a large study of over 10,000 women over the age of 50, and they surveyed them every 2 years between 2004 and 2010. What they found was that incontinence prevalence increases with age, which I think comes as no surprise to anyone who's accustomed to treating this population. We know that age is a risk factor for incontinence. But what they did find is that there's some variability depending on the type of incontinence. So among women with urgency incontinence, the prevalence didn't tend to increase linearly by each decade from the 50s into the 90s. Similar trend with mixed incontinence, where there is this linear progression, but that does not begin until the 70s, so a little bit later in life. And what's not listed on this slide, but stress incontinence actually tends to remain pretty flat over time. So, women, often younger women, will develop stress incontinence, but those prevalence rates don't actually change that much over time. They did find that remission can occur, and if it occurs, it's more likely to occur if you have stress incontinence, and much less likely to occur if you have mixed incontinence. But I think the biggest finding from this study was thinking about predictors of recurrent incontinence over time, and that was having a prior history of incontinence. So if women had incontinence at time point A, they had a 25 times greater odds of incontinence at the end of the study. And if they had incontinence at 2 time points, that was even higher, 30 to 40 times greater odds of recurrence at the end of the study. So having a history of incontinence is a very strong predictor of recurrence. I want to pause for a moment. It's not listed on this slide here, but a lot of these studies have been looking at older women, so kind of in ages 50 and up, which is the population that tends to have the most prevalence and incidence of incontinence. But we see similar trends when we look at the pregnancy and postpartum population in terms of this idea of having had a history of incontinence, then predicting whether or not the pregnant or postpartum woman will develop incontinence. So we see this at younger ages as well. We just have lower prevalence rates overall in those populations. So we'll close out sort of these large-scale population studies and then shift our attention to how women with incontinence differ from those who are continent. As I indicated, a lot of studies are really focused on older women and particularly postmenopausal women, but there have been some studies looking at younger and premenopausal women. This particular study looked at disability scores, so looking at a global survey of disability to compare to women with and without incontinence. And this survey gives a kind of a total disability score, but then also domain-specific scores in areas of cognition, mobility, and a few other domains as well. I want to highlight their findings here. So overall, women had significantly higher disability scores, their total score, and on these cognitive and mobility domains as well. We'll speak in just a moment about sort of the physical decline and physical effects of incontinence. But I want to look at these cognitive findings here. So what is it that might underlie this kind of lower cognitive performance among women with incontinence? So overall, if we think about the act of continence, it does require executive brain functions. So initiation, planning, voluntary control, certainly, and this idea of divided attention. So meaning that you can attend to one task, perhaps while you might even, you might have an idea in the back of your mind that you need to use the bathroom, but it's not overtaking you so that you can focus on this task at hand. And what they find is, particularly women with urgency incontinence, when they look at their brains and the functional MRI studies of what's happening at the cortical level, they find that there's an increased response to this sense of urgency among women with incontinence and those without. And then this kind of has been translated into some other more performance-specific studies where women perform lower on dual performance tasks compared to women without incontinence. So meaning they, sort of more of their brain real estate is tied up managing this incontinence so that they're not able to perform as well on some executive functioning tasks. If we think about physical performance and physical decline, we also see that women with incontinence tend to perform or score lower on tasks of physical performance. This particular study actually looked at, that began with women who were all continent, and they assessed them at baseline, and then they assessed them 4 years later. So at baseline, all women were continent. They were able to walk a quarter of a mile, climb 10 stairs, and complete all of their basic activities of daily living. So on the whole, quite functional. In the 4-year interim, about a third developed incontinence. And what they found was among those who developed incontinence, there was a greater decline in physical performance. Now, all women did decline some because we're looking at older women. I believe it was 65 years and older in this study. But those with incontinence declined significantly more. And they found that women with incontinence had a greater odds of developing sarcopenia. So having greater declines in muscle mass was associated with developing incontinence. There's been some other studies that have also looked at physical decline and physical function, again, sort of supporting this idea that women with incontinence have both greater and faster physical decline compared to continent women. And the contributors to this are sort of multifaceted and can be kind of bi or multi-directional. So yes, you have women who have incident incontinence. We know that they tend to start avoiding certain activities and exercise so that they can avoid leakage. And then this in turn contributes to a decline in physical function and decline in strength and things like that. On the flip side, we also know that declines in strength and mobility can predict the onset of incontinence. So, you can develop UI from that direction as well. But sort of once these gears are in motion, you sort of end up in this cycle where you have incontinence, it becomes more severe. You have greater physical decline, which contributes to then increasing severity of incontinence. So the wheels kind of keep spinning from there. We can see this supported in some kind of broader evidence where researchers have looked at urinary incontinence as a risk factor for other types of things, such as hospitalization and admission to nursing facilities, care dependency. So women with incontinence tend to have a greater likelihood of functional dependence and are more likely to require care for their basic activities of daily living or for their instrumental activities of daily living. We know they're more likely to report lower physical activity rates, more likely to experience falls. So lastly, I'd like to, so we've kind of started from this large population perspective and really painted quite a broad picture of incontinence and what that looks like for the population of women with incontinence. But I'd like to think now about the individual and how individual trajectories of incontinence can vary, according to a variety of circumstances. So this lifespan analysis of pelvic floor function was put forth by Delancey and colleagues. And this is just one of many possible trajectories that a woman could follow who develops incontinence over time. So on the y-axis, you see pelvic floor function, which is a little bit of an abstract idea, but just sort of this idea that, from birth till a certain point, we can develop a certain level of pelvic floor function based on our genetics and our childhood and many contributing factors that can kind of predict how the function of our pelvic floor will be when it peaks. And then across the x-axis, of course, you can see time by decade. And then you have this sort of symptom threshold that's delineated there. So this author group looked at these sort of three phases. They're not exactly linear, even though they're sort of portrayed that way on the graph here. We'll look at each of these to think about how pelvic floor function is affected over time. So phase one, thinking about predisposing factors. So again, those are the things that are going to kind of dictate this idea of pelvic floor function, things like genetics, nutrition, and socialization. So thinking about toilet training and toilet habits that develop from a young age and how that might affect the function of the pelvic floor early on. Then we have this idea of inciting factors. So things that can kind of acutely affect the pelvic floor function at one time point or potentially multiple time points. So I think the most obvious are pregnancy and childbirth. And again, that can be multifactorial in itself. So maternal and fetal factors, right? The size of the infant, the size of the head circumference of the infant when it's born. A variety of obstetric interventions that could take place, so whether it's an instrumented delivery or cesarean section, and then the type of injury and tissue damage that can take place, so perineal tears and things like that. You might also think of other types of inciting factors. Certainly, assault could be one, or any kind of, maybe childhood cancer. There's a variety of inciting factors that could take place, but we know pregnancy and childbirth are the two primary ones. On this graph, you see that happens at one time point, but you can imagine that people can have multiple pregnancies and births, so that you could have several inciting factors along this trajectory here. And for some women, that inciting factor may actually dip below the symptom threshold. So in this depiction, it has not, but some women will develop incontinence immediately postpartum, and then it'll come back above that symptom threshold and potentially carry on for some time before it reaches that symptom threshold again. And then lastly, we have this idea of intervening factors, which again is not necessarily linear, but can be kind of contributing to pelvic floor function, over time and across time. And these are things like variability in just normal aging, so muscle and connective tissue aging, but also things like stress to the pelvic floor, so occupational stress, if someone has a job where they're doing repetitive or heavy lifting, obesity, and respiratory illness, which we know is associated with increased risk of incontinence. We also have other factors that could weaken the pelvic floor, so medications or even just disuse because of a sedentary lifestyle. And then other factors such as exercise, the availability of bathrooms. So we think about certain populations that may not have access to a bathroom for a period of time. So they're developing bad habits such as fluid restrictions or other kind of bad bladder habits over time. All of that will also play a role in pelvic floor function and when symptoms onset. So you can imagine, again, this just being one of many, many possibilities for an individual patient's trajectories across time. I'd like to then kind of turn this to talking about sort of a fictitious patient, but a patient that may resonate with any provider that's interviewed a patient with incontinence. I start with this quote from a focus group. Incontinence does not kill you; it just takes your life away. So really, it truly is a quality of life disorder. It's not necessarily going to lead to increased mortality, but it is a major issue, and one that warrants our attention and addressing as healthcare providers. So we'll talk about Jane, our fictitious patient here. So Jane was born in 1945 and had a very happy childhood, and took up playing tennis as a young girl, and really was an avid tennis player for some time. It's very active. She got married in 1966, and very soon after was pregnant with her first child. She had her baby and had a second baby very soon after that. At the time of her second delivery, though, she developed a little bit of incontinence, but just a little bit, kind of stayed for a month or two, but then her symptoms went away and she was busy raising her two children. She had a third child in 1972, and again had this little bit of incontinence that developed around the postpartum period, but then went away. And then again, fourth child in 1974, and again a little bit of incontinence there, but nothing that stuck for some time. And by 1980, she was the proud mom of four children, but she did have these four major risk factors for developing incontinence later in life: pregnancy and childbirth, as well as having had this history of incontinence, even though it went away during those time periods. By 1995, all of her children were off to college and high school, and she decided to pick up tennis again at this time. And what she noticed there is that she started to have some leakage, but it wasn't so bad. She was managing it with panty liners, and it seemed to only happen when she was playing tennis, so she didn't worry too much about it at that time. Then she hits menopause in 2000. And at that time, she noticed her incontinence start to get much worse, and in fact had a full loss of her bladder during one of her tennis matches. And this was enough that it was embarrassing enough for her that she decided to stop playing tennis altogether. She moved on with her life and ends up becoming a grandmother in 2005, and at that time just became the primary childcare provider for her grandchild. And what she noticed soon after that, as the baby's growing and she's doing a lot more lifting and running around, is that her incontinence came back again. And so this time she's managing with panty liners again, and but developed some more restrictive habits in terms of watching her fluids, going to the bathroom before she leaves the house, and even limiting some of her activities outside of the house. And at this time, we see some of her stress incontinence symptoms transition to mixed incontinence. So she's having some urgency symptoms as well. She's getting up at night to go to the bathroom. And then she has a little bit of weight gain as well. 2020 rolls around, and these symptoms are pretty persistent during that time. She wakes up at night and has a fall on her way to the bathroom, and sustained some orthopedic injuries during that time. And it's at this time that she really starts to take a look at what, is she going to be able to live alone? Is she going to require help? It can be quite depressing, and really her future feels like a big question mark. So she's really having to revisit her own independence and at that time. So this is just one story. I think it's perhaps a familiar story to many providers, especially those who are treating older patients. And you can imagine, based on all of the things we've discussed, there could be a variety of stories that look a little bit different, or that look similar to this. I'll close here, unless you want to add anything, Jessica.
I just want to add, I think this has been fantastic. I think it really is, as each of us have been kind of career-long clinical healthcare providers, it's still stunning to see, in the earlier studies, such huge numbers of women who don't get care. And, the comment that, remission is not because of intervening treatment. And I think too about that in connection to the importance of the history taking, and this sense of not addressing it feels a lot like kicking a can down the road. And I think that it just really, I have read all these papers and been close to these discussions with you, and continue to find myself so moved by this data, and think of what an opportunity it really is um, for the healthcare community, to kind of lean in a lot more on helping women through this at multiple different touch points in life.
I think you're absolutely right. And I kind of leave that question mark at the end there. And as you know, I've been a women's health provider for a long time, but I also have a variety of experience working in acute rehabilitation settings and things like that. And the discussion around incontinence doesn't happen by the time you get to the end of this timeline. There's a discussion around functional independence and assistive devices and caregivers and things like that. But in my experience, and I'm sure it could be different in different settings, we're not generally looking at this long history to say, hey, maybe this person requires some intervention for their incontinence, and we can get them more functionally independent and contribute to to that for a longer period of time. So I think to your point, this conversation is warranted at multiple touch points across the lifespan.
Okay.
Yeah.
This has been great. So
Thank you.
thank you, Laura, for really leading this presentation, and thank you to everyone who will be tuning in to this after the fact. If you watch it, we'd love to hear from you. If you have this, you know how to contact our provider support line. And if not, we're really easy to find. We hope this has been useful, informative, and thought-provoking. We've certainly enjoyed the process and the preparation. So thanks again, Laura. Thanks to everybody tuning in.
Great. Thanks.